Hey everyone, and welcome back to my channel, and today I am going to be doing a very highly requested video. I've had several people comment on my radio report examples or send me a message and just ask me how I set up a narrative. So today I'm going to present to you a completely made up patient care report or narrative. And just remember, just because I write my reports in this format does not mean you have to, or doesn't mean that you can't add or subtract things. Everybody writes their reports different and everybody has a different style, and this is mine. Let's jump right into it. So as we know, the D is for dispatch. In the dispatch portion, I actually include quite a bit. So for example, I let you know where I'm located. So Atlantis Fire Station number 1 is dispatched, and then I go ahead and I give the address. And I always put the reference and the age and the gender of the patient. In this case, 400 North Appleton, in reference to a 47-year-old female experiencing abdominal pain. So Medic 1, which would be my unit number or my ambulance, responds code 1 from Atlantis Fire Station with 3 personnel, and I always include the personnel's name in parentheses. Now we know who all was on this call: Paramedic Jackson, Advanced EMT Smith, and NREMT White. Then I talk about what happened while I was en route to the call. So while en route, dispatch advises that the patient can be found outside the residence. Then I talk about what I see whenever I get onto the scene. Upon arrival, EMS is directed toward the curb. Now I talk about how I found my patient, their condition. Patient is found standing on the curb, bent at the waist, clutching her stomach. The patient is in obvious distress. So now I've painted a picture. I've told you what dispatch told me ahead of time, and now I've told you what I pulled up on scene and saw. And that's pretty much what I include in the dispatch section. Some people include a lot less. Some people will just include the reference and the address. So next is the chief complaint, and this is pretty self-explanatory, the chief complaint of the patient. In this case, the patient is complaining of bilateral flank pain and lower abdominal pain. And that's pretty much all I put on the chief complaint section. Next goes into the H section, which is your history section. And this is where I include my ample and my OPQRST. So my ample includes allergies, which are to Toradol, medications that the patient is currently on, and that's lisinopril, past medical history, hypertension, so obviously the patient takes lisinopril for their hypertension, and kidney stones. So now we know that this has probably happened to the patient before. Just knowing where the patient's pain is and how the patient's presenting, chances are she could be experiencing kidney stones again. L stands for last oral intake, breakfast burrito about 5 hours prior, and the E, which is the events leading up to. So the patient stated she had a sudden onset of flank and abdominal pain, and the patient states that there is blood in her urine and the stream was abnormal because it came out in spurts. So I put in spurts in quotations because that's specifically how the patient described it to me. The O is for onset. So what was the patient doing whenever the patient started experiencing pain? She was awakened by an intense pain, and it started about an hour prior, and it has only gotten worse. The P stands for provocation or palliation. Nothing makes this patient's pain better, and it is worsened specifically whenever there's palpation to the abdomen and or when the patient is attempting to urinate. The quality of the pain, how the patient is describing the pain to me, it's an excruciating dull pain. And the R is for radiation. So where is the pain radiating to? And the time. So when did it start? It started about 1 hour prior. And this is pretty much all I include in the history. All right, now going into the A, which stands for assessment. The first thing I always start off with is the patient's mental status, or LOC. So the patient is alert and oriented to person, place, time, and event. Then I go into ABCs. So my airway is currently patent with no obvious obstructions or excessive secretions. This is just saying from a general assessment point of view, I don't see anything obvious. Then I go into lung sounds. Lung sounds are clear bilaterally. Next, I go into the patient's work of breathing. So patient appears to be having no difficulty in breathing and is able to speak in full sentences with ease. And this I feel like is very important, because if we have a patient that has difficulty breathing, a lot of times they may be tripoding, or they may be just answering by nodding their head or shaking their head, or even just yes or no kind of answers. But I've made it clear that this patient is not having any difficulty breathing. She's able to speak in full sentences. Next, I go into circulation. Circulation is intact with no current external hemorrhage. So this is basically just saying that from the outside, a rapid visual head to toe assessment, I don't see any obvious bleeding or trauma. The patient is visibly upset and crying. So once again, I'm just I'm just painting that picture of how that patient is presenting. She is in a lot of pain because if you've ever had kidney stones, they are an extremely painful condition. Pupils are equal, round, and reactive to light. The abdomen is tender to palpation in the left and right lower quadrants, and rebound tenderness is noted. When you've done your head to toe exam and you've palpated the abdomen, just note where the patient is hurting and if they're experiencing rebound tenderness, which many times can indicate that there is some kind of infection or something going on. Flanks are tender to palpation as well. The skin is noted to be warm, so this may mean that the patient does have like a low-grade fever. The patient does confirm a history of UTIs and kidney stones. And I always ask the patients to give me, on a scale from 1 to 10, and 10 being the worst pain they've ever been in, a rating of their pain. And so she says she's in 10 out of 10 pain. She states childbirth is the worst pain she's ever been in, and she's still rating this a 10 out of 10. So I know she's in pretty intense pain. So the patient does confirm pain upon urination, and I do go ahead and note her blood glucose level being 121 and her temperature being 99.9 degrees Fahrenheit. And that's pretty much it for my assessment section. You can add on to this, you can subtract from this, but I feel like you've gotten a pretty good idea of what all I've assessed. And the R section is for treatment, like RX. So the first thing I always start off my treatment section with is the patient assessment is performed, because that's the first thing that we always do. And if there's any questions about what was found during the assessment, you can look up in the section above. So I basically talk about the fact that the patient walks to the gurney and is moved into the ambulance. So this tells the person reading the report that the patient is ambulatory. So once again, just painting a little bit more of a picture. Once the patient is in the ambulance, the patient is placed in a position of comfort. I just note in there that all the seatbelts are applied, and that's just one way to cover yourself and also make sure that your patient is safe. And then I talk about what I actually did to this patient. So the first thing I put are vitals are taken and R is recorded. So in the patient care reporting system that I have, vitals are a separate section. So it's not something that I include in my narrative. I just indicate that vitals have been taken, and you can look in the vital section to find those. There are certain situations where I would include the vitals, say a patient's super hypotensive and we have to end up giving dobutamine or dopamine or something like that, then I would definitely note the vitals within the narrative. There are certain situations that I would do that in, but for the most part, I just indicate in my treatment section that I've taken them. Then I go into a 20 gauge IV is established to the left hand, and patency is ensured with a flush of normal saline. So once again, I'm just letting you know the gauge of the IV. I'm letting you know where we established it and that there was no infiltration or anything like that. Now this next line is something that I learned from a flight nurse. No redness, tenderness, or signs of infiltration are noted to the site. If a line were to infiltrate later on or something ended up happening, you're covered because you put in your report that you've checked it and patency was maintained the whole time. So something that we do for our local hospital is get a blood draw. This just helps them out because once we get to the hospital, they can immediately go and send that blood off to the lab. So I noted in there that a full rainbow blood draw is obtained. I let you know that I did administer 50 micrograms of fentanyl and what I administered it for. And then I also note in there how much fluid I gave them. So out of a 500 milliliter bag of normal saline, I gave 350 milliliters. The patient is now rating her pain a 6 out of 10 by the time of our arrival at the hospital and is requesting to use the restroom. This just tells you how we treated the patient and the patient's status as we pull up to the hospital. And as we know, the T stands for transport. In this section, I basically just talk about how the transport went. So patient is transported code 1 to Atlantis General Hospital. In that part, I would let you know if I was going code 1, code 3, if I ended up upgrading while en route to the hospital, etc. Patient's condition is monitored and reassessed during transport with slight improvement noted. This is just saying that I watched the patient, I treated the patient, and what I did for the patient caused a slight improvement in their status. AGH is contacted via radio and advised of the patient's condition, treatment, and our estimated time of arrival. So you'll notice that I said AGH, and that is only because at the beginning of the transport section, I did say Atlantis General Hospital. I have contacted them via the radio and I've let them know everything I've done and when we're going to be arriving. Next, I talk about what they advise. So AGH advises no changes in patient care, and upon our arrival at AGH, the patient is placed in an ER bed 23. This is something I try to include in all of my reports, and a verbal report is given to RN Jessica Smith and signatures are obtained. This is something that I always always record to just have further documentation of who I transferred patient care to, and also that signatures were obtained. And if for some reason your tablet wasn't working or you weren't able to get signatures, this is where I would explain why I wasn't able to get signatures. At this time, the patient's care is turned over to AGH. Medic 1 is clean, restocked, and returned to Station 1. And that's how I end my reports. And then I sign with my name, my employee identification number, and also my registry level, so nationally registered paramedic. And that's how I write my narratives. I mean, give and take some of the information in there. Obviously, some things are going to be different if it's a trauma report or if it is a code report or something like that. Things are definitely going to change, but that's generally the format that I go with. And I usually don't use the E portion, the exceptions portion. So this is what it would look like all together. So that's the D chart, DCHART. And then, like I said, I usually don't use E, but you can use E for exceptions. So that's pretty much it. I've never used the SOAP format. It's something kind of foreign to me, but it is something that we learn about within EMT or paramedic school. And as always, on these reports, you want to use spell check. If you can see on this report, there are a few things that are underlined with the spell check, like Toradol, Zofran, patency. And when I see stuff like that, I make sure that it's just because it's a brand name or something like that and not because I actually misspelled it. And definitely going back through your reports and your narratives and rereading, there's been so many things I've left out words, or, I would be embarrassed if it ended up getting subpoenaed and going to court. Just kind of proofread it. It's just really important. All right, y'all, I hope this helped, and I for sure am going to do more of these in the future. I'll do an example of a code narrative and, a trauma narrative, things that we commonly run on within EMS. Thank you guys so much for watching, and I will see you next week. Bye.